I am going to discuss a bit about the role of selinexor in combination with bortezomib and dexamethasone in some specific subgroup of patients with multiple myeloma in the relapsed and refractory setting, but specifically after just one prior line of therapy. And the rationale for this two presentation is based on the Boston study. It is a phase 3 clinical study in which selinexor, bortezomib, and dexamethasone was compared with bortezomib and dexamethasone in 400 relapsed and refractory myeloma. And the study met its primary endpoint, benefiting progression-free survival for selinexor, bortezomib, and dexamethasone with a hazard ratio of 0.7 and a median progression-free survival of 14 months for SVD versus 9.4 months for VD alone. And when we evaluate how the treatment landscape is evolving in multiple myeloma, and especially in the first line of therapy, we are going to face more and more at the moment of the relapse with the patients refractory to lenalidomide, as well as also with patients refractory to daratumumab and lenalidomide. And we are going to face with some patients even naive for proteasome inhibitors. And these two abstracts are basically focused on relapsed and refractory myeloma after just one prior line of therapy, focusing on patients naive for proteasome inhibitors as well as refractory to lenalidomide. And these are the two abstracts about what I would like to discuss. The trial design was randomized phase 3 clinical study in 402 relapsed and refractory myeloma patients after at least one and more than 3 prior lines of therapy. Selinexor, bortezomib, and dexamethasone as continuous therapy was compared with bortezomib and dexamethasone also as continuous therapy, and the primary endpoint for this study was progression-free survival, and key secondary endpoints included overall response rate, VGPR rate or better, as well as grade 2 or more of peripheral neuropathy. This is the study design for the Boston study, but if we concern on the sub-analysis presented at EHA 2023, I would like to say that the first abstract is focused on the updated results for this Boston study by the number of prior lines of therapy. Well, according to my answer, if we focus specifically on patients treated with just one prior line of therapy, in the Boston study, approximately 200 patients were treated with after just one prior line of therapy. Baseline characteristics for SVD and VD were comparable, and majority of the patients did present an optimal performance status, and approximately 50% of the patients in both arms presented high-risk cytogenetic abnormalities. And important to note that approximately 30% of the patients had been previously treated with autologous stem cell transplantation, indicating that majority of the patients will be non-eligible to autologous stem cell transplantation. And this is important because this is a specific subgroup of patients in which we plan selinexor, bortezomib, and dexamethasone as the first choice. In this sub-analysis, when we evaluate the outcomes in terms of progression-free survival for patients treated with selinexor, bortezomib, and dexamethasone over bortezomib and dexamethasone treated with just one prior line of therapy, the benefit is quite consistent. The hazard ratio for progression-free survival is 0.62, and the median progression-free survival is 21 months for SVD versus 10.7 for bortezomib and dexamethasone. And this benefit is derived also from a significant benefit in terms of overall response rate, 81% for SVD, including almost 1/3 of the patients achieving complete response. And in addition, in this specific subanalysis, we decided to focus on patients naive for proteasome inhibitor, because if we consider that the first line of therapy, especially in the transplant population, is daratumumab in combination with lenalidomide and dexamethasone, this means that the majority of the patients at the first relapse will be naive for bortezomib and naive for proteasome inhibitor. And this subanalysis has been also conducted in the Boston study, and there are approximately almost 100 patients treated with SVD and proteasome inhibitor naive after just one prior line of therapy. And what we can see is how the hazard ratio for progression-free survival does continue being very significant for Selinexor, bortezomib, and dexamethasone, 0.29, and the median progression-free survival for SVD was almost 30 months versus 9.7 months for bortezomib and dexamethasone. And the same data were observed when we focused not only on patients after one prior line of therapy and naive for proteasome inhibitors, but in addition, bortezomib naive, and the median progression-free survival for SVD was also approximately 30 months. In addition, with the great benefit observed for SVD in patients after one prior line of therapy and proteasome inhibitor naive, the other challenging situation is the len refractory population, because basically majority of the patients after just one prior line of therapy will be refractory to lenalidomide. And this is the second subanalysis presented at the European Hematology Association Congress. How is the outcome for patients treated with selinexor, bortezomib, and dexamethasone if they are refractory to lenalidomide? I have to say that 106 patients included in the phase 3 Boston study were refractory to lenalidomide. No significant differences according to the baseline characteristics between both arms, but it's important to note that majority of the len refractory patients included in the Boston study had received 2 or 3 prior lines of therapy, and only approximately 1/3 of the patients had received only one prior line of therapy. This is related with the standard of care at the moment in which the Boston study was conducted, but in spite of this fact, Selinexor added to bortezomib and dexamethasone resulted in a longer median progression-free survival in comparison with bortezomib and dexamethasone alone, 10.2 months versus 7.1 months. And this benefit was also observed in terms of overall response rate, as well as a complete response rate and VGPR rate or better. This means that while selinexor, bortezomib, and dexamethasone is also superior to VD in the len refractory population, although it's true that more data will be required from the len refractory population after just one prior line of therapy, but maybe this data will be generated in the real life. Selinexor, bortezomib, and dexamethasone is a new standard of care already approved by the authorities for relapsed and refractory myeloma patients after just one prior line of therapy. Now, according to the treatment landscape for newly diagnosed myeloma patients, we are going to basically face at first relapse with patients dara and len refractoriness, and in some cases even naive for proteasome inhibitors. And from my point of view, this means that this combination could be a good option for these patients just relapsing or progressing after one prior line of therapy. Of course, beyond the first relapse, it is also possible to utilize selinexor, bortezomib, and dexamethasone based on the efficacy and safety data reported in the Boston study.